Okie dokie. So this is chapter 2 of degenerative nursing disorders. So chapter 1 talked about multiple sclerosis and Parkinson's disease. I'm going to share my screen. So the last slide that I talked about was about Parkinson's disease. But let's get into myasthenia gravis. So myasthenia gravis is, for those of you who are like word nerds, it's deriving from Greek. And so it's a combination of mus and stenos, which means muscle and weakness, and gravis meaning severe, gravitas. So what it is these people have really significant fatigue. They feel strongest in the morning and then after periods of rest, and then their signs and symptoms will be worsening in the evening. Their face is affected by fluctuating muscle weakness. So you'll see changes in their eyes and in their eyelids, as you can see with these particular pictures here. We've got some, oopsie, meant to grab a pen. There we go. So as you see, we have a definite problem, or not definite difference rather, in the eyes and in the eyelids. You'll also see chewing and swallowing problems, speaking problems, and of course, ABC problems with breathing. So these people will have problems and problems getting adequate ventilation as their signs and symptoms progress. So it's harder to breathe in the evening as well, which then creates more fatigue, kind of a vicious cycle. These people also have incontinence. They have poor posture. And this, again, is one of those things that has exacerbations and remissions. So you will see people who are having really great times during the remission and very little symptoms, and then they'll run into an exacerbations time, just like with the people that we talked about who have multiple sclerosis. So the big darn deal with myasthenia gravis is there's antibodies attacking the receptor sites at neuromuscular junctions, and that attack blocks acetylcholine. And it impairs the neuromuscular transmission to skeletal muscles. So what you see here is the peak test. These people can't keep their eyes closed. So a person with myasthenia gravis will, the peak test really is just like peaking, where I think it's after a certain period of time. The length of time escapes me at this moment. But what it is we will have the patient close their eyes, and then eventually, through no voluntary action of their own, their eyelids will open just a little bit and peek at us. So for diagnosis of myasthenia gravis, we're going to be doing a nice thorough H&P. We'll be looking at fatigability with upward gaze, meaning we'll have them look like, keep their face forward, but looking up at the ceiling, and the persons who are affected by myasthenia gravis will not be able to maintain that upward gaze. We will also do an EMG, which can show muscle weakness with repeated stimulus. EMGs are basically, I had one done on my arms. What happens is they just took a look at, they sent some pulses down the muscles of my arms to see if I had any weakness in them. And so it's looking for muscle weakness with repeated stimulus. There's also a tensilon test. If the signs improve after the tensilon, then it's positive for myasthenia gravis. If for whatever reason you're doing the tensilon test and you've got problems, atropine will help, is the reversal agent for that tensilon. And then if we are doing a really specific blood test, we will see some anti-AChR antibodies present in about 90% of the people who have myasthenia gravis. but it's not present in 100, so it's not considered an absolute diagnostic test, but it's part of the array of diagnostic tests that these people are using, or that teams use to be able to help people with this diagnosis or determine this diagnosis. Just like with Parkinson's disease, we need to give the meds on time, just like our antibiotics or seizure meds. If it involves the nerves, the meds need to be on time. Different medications that are associated with this particular condition include pyridostigmine bromide, which helps facilitate the transmission of impulses through that neuromuscular junction. Remember, that's the root cause of this problem. So if we can get those transmission of impulses through that problem, then that's a definite help. They may be taking every other day or alternate day corticosteroids, immunosuppressants. They may have a thymectomy, thymus gland, plasmapheresis and IVG, where they'll actually be given, their plasma will be taken off. They will actually be given back their plasma with some things scrubbed out. IVIG, they can get IV immunoglobulins, and we need to, there's a lot of drugs here. We need to be really, really good at knowing what different types of stuff we have going on with those medications so that we don't accidentally create more problems. For nursing interventions, the primary nursing intervention or the primary problem expressed by people with myasthenia gravis is activity intolerance. And you'll see the nursing interventions are listed in the book. But here are the other nursing problems that are, or diagnoses that are associated with this particular problem. Ineffective breathing pattern. Like I said, they can have ineffective breathing pattern and airway clearance, impaired verbal communication because of those problems with the muscles in the face, imbalanced nutrition, less than body requirements. Again, if they're having problems with talking, then they're also most likely having problems with chewing and swallowing as well, because it's all related in here. Disturbed sensory perception because of the eyelid drooping, as well as disturbed body image can be coming into play as well. So people with myasthenia gravis can have a myasthenial crisis. And a myasthenial crisis is acute exacerbation of that muscle weakness related to infection or stress or surgery. Maybe they have too much meds, maybe they don't have enough meds. Usually it's under medication. So they have not gotten enough they're outside of therapeutic levels, and they're less than therapeutic. So signs and symptoms of a crisis include increased blood pressure, increased heart rate, severe respiratory distress. They will have cyanosis in their mucous membranes. They will be blue, they will be blue, they will be blue, they will be blue in their mucous membranes in the back of their mouth. They also may have increased secretions, absent cough and swallow reflex. Those two don't work very well together because they end up with aspiration of that saliva. Increased sweatiness, diaphoresis, increased lacrimation, restlessness, dysarthria, bowel and bladder incontinence, severe muscle weakness. So what we're really looking at, and this is an airway crisis situation, so they need to maintain adequate ventilation. So one of the things that we can do is administer anticholinesterase, otherwise known as pyridostigmine. The other thing that we can do, these patients may be on the vent for a little while as we're getting them through the myasthenia crisis, just so that we can keep that airway. A cholinergic crisis can also occur, and that's an acute decrease in the need for anticholinesterase, and that results in over-medication. And so signs and symptoms of cholinergic crisis, just to go back, is we've got this administering anticholinesterase here. We also have, and we're going to hold the anticholinesterase here and administer atropine, just so that you're aware. what a cholinergic crisis looks like, we have nausea, vomiting, abdominal cramping, diarrhea, blurry vision, pallor, they're pale, facial muscle twitching, papillary meiosis, and hypotension. Lastly, I'm going to be talking about amyotrophic lateral, oh no, not lastly, I'm sorry, I've got one more after this, but ALS, otherwise known as Lou Gehrig's disease. With this particular problem, what happens is the motor neurons in the brainstem and the spinal cord gradually degenerate. So any electrical or chemical messages from the brain don't reach the muscles. These people are cognitively intact and they are trapped inside a body that cannot support them anymore because their motor neurons and their spinal cortex can't perform well anymore. So you'll see a lot of people with ALS that are sharp as a tack, but are unable to communicate without the help of, sometimes they use communication computers. You'll see them they'll be in motorized wheelchairs, and being able to control that perhaps usually with their eyes, because that the eyes aren't always associated with motor neurons in the brainstem. So this one hits me hard because I had a friend who passed away from complications from ALS not too long ago, a couple of years ago. So. Huntington's disease, there is no cure, and it is genetically passed from one family member to the other, from the parents to the offspring. Offspring have 50% chance if the parent has it of having it as well. So most everything is caused by an excess of dopamine in these particular people. So in Parkinson's, there's not enough dopamine. In Huntington's, there's too much. So people will have excessive writhing, twisting, and involuntary movements, not tremoring, but they will be moving in involuntary ways, otherwise known as chorea. They will also have cognitive deterioration in terms of perception, memory, attention, and learning. There could be irritability, anxiety, and agitation associated with this as they're having the cognitive degeneration. We can use risperidol and haldol to help with those particular psychiatric problems by treating them with antipsychotics. These people will lose a lot of weight due to malnutrition because they have deteriorating chewing and swallowing abilities. And because of this excess movement, the writhing, twisting, involuntary movement, these people need a ton of calories per day to be able to maintain homeostasis, 4,000 to 5,000 calories a day. Like, these are professional bodybuilder levels of calories per day. And that's what a person with Huntington's disease will need to be able to keep up with the energy demands from that constant involuntary movement. In terms of nursing care, we're going to be providing nursing diagnoses. We're going to be looking at their comfort. We're going to be looking at their safety, especially if they're having problems with anxiety, agitation, irritability, and cognitive deterioration. We're going to be looking at treating the physical signs and symptoms and providing emotional and psychological support, maybe not only for the client, but for their family members as well. There are some neurologic diagnostic procedures that we have talked about throughout this, both chapter 1 and chapter 2. These can be used for any sort of neurological problem. So this is outside of Huntington specific. Globally speaking, neurologic diagnostic procedures include cerebral angiogram. What a cerebral angiogram is, a special type of it's a special type of test where we're actually looking at how the blood flows through the brain. There's cerebral computed tomography, CT. You can do EEGs, Glasgow coma scales are something that the bedside nurse does a lot. Any sort of nurse can do, and whenever. Remember that the minimal, you can't score less than a 3 on a Glasgow coma scale. You can score up to 16. There's ICP monitoring. You're going to learn about that in high acuity class because that is an invasive thing. There's lumbar punctures, otherwise known as spinal taps. MRIs. You can do PET scans. There are SPECT scans and there are x-rays. So here's what my advice to you is. For each neuro disorder that that I have talked about both in chapter 1 and chapter 2 for YouTube's, what are the major nursing interventions? What are the priority nursing diagnoses? And were you to create a teaching plan for a person who with a recent or with a continual or maybe a long-term diagnosis of one of these problems, what are you going to include? So to help you process what I've talked about for the past 45 minutes between the two slideshows is, what are the major nursing interventions? What are your nursing diagnoses? And what would the teaching plan include for these people? With that, I'm going to stop sharing and I'm going to stop recording. Please feel free to reach out to me with any questions that you might have, and I will see you soon.